So we will go on to the next speaker who will be joining us online. It is Professor Samir Naim Asaad. He is an emeritus. يده موجود الدكتور.
أهلا.
Dr. Professor Samir Asaad is currently an emeritus professor of medicine and endocrinology at Alexandria University Medical School in Egypt. He served as the chief division of endocrinology from 2011 to 2014, as well as the head of the Department of Internal Medicine from 2013 to 2014. Obtained his medical degree from the Alexandria Medical School and completed fellowships in endocrinology at MD Anderson Hospital in Houston, Texas, USA, and Western General Hospital in Edinburgh, United Kingdom. And he was elected as the Fellow of the Royal College of Physicians of Edinburgh in 1996. Professor As'ad was also an assistant editor in the Journal of the Egyptian Society of Endocrinology, Metabolism, and Diabetes, and he has more than 50 scientific papers published in national and international journals. He has supervised more than 40 theses in the field of endocrinology and diabetes. His research interests include diabetes mellitus, obesity, thyroid, and pituitary disorders, and he is a member of a number of associations, including the Endocrine Society, the European Society of Endocrinology, and the European Association for the Study of Diabetes. We'd like to welcome him, and today he'll be talking to us about thyroid nodules, the dilemma of the thyroid nodule. We'd like to welcome you, Dr. Samir, and you have the stage.
Thank you very much. Good morning, everybody. Assalamu alaikum. Thank you, Madam Chair Lady, for the nice introduction. And I'm really happy to be among this distinguished group of diabetologists and endocrinologists in Yemen. And thank you, of course, to Dr. Zaid, a very dear friend for us here in Alexandria, and for the kind invitation. Thyroid nodule, and as you know, although this is a diabetology ultrasound, the 6.8 they did have a thyroid nodule, and 7% of these nodules were actually having differentiated thyroid cancer. So this is data to other areas as well. So almost 5 to 6% incidence of nodules. This is patients who are 20 to 50, because after the age of 50, particularly in ladies, you can go up to 40% ultrasound nodule shown. Now, the dilemma for us physician and for the patient is three questions. Is the nodule malignant? Do I need to do fine needle aspiration biopsy, or do we have to remove the thyroid? So this is the three main questions. I'll try to answer this question shortly, inshallah. And you can see that there are different types of thyroid nodule. You can get benign lesion like follicular adenoma, focal thyroiditis, colloid nodule, thyroid cyst, whether pure or cystic nodule, hyperplastic nodule, and lastly is the important dilemma is the thyroid cancer. And thyroid cancer we differentiate into is divided in differentiated thyroid cancer, non-differentiated, the differentiated papillary, follicular, and follicular, and the non-differentiated medullary anaplastic. Of course, the prognosis in the last two is quite bad, but in papillary is the best prognosis. And two recently introduced terms like papillary thyroid microcarcinoma, in which the tumor is less than 1 centimeter, and the NIF-FT, which is invasive follicular carcinoma with papillary nuclear features, and these are very, very low risk category. And not to alarm the physicians everywhere, I'm going to this study by Dorenti 10 years ago, in which they have studied benign nodules documented by ultrasonography and biopsy, and they showed that no significant size increase over the years. And this is important because many patients think I should remove the thyroid nodule because it might turn malignant, and there is no evidence for that. Usually the tumor nodule is benign starting. Usually it's very, very, very rare to change into malignant. And this is a very important part for the physician. In my talk, I'm going to allude to the important guidelines, the American Thyroid Association guidelines, 2015, the European Thyroid Guideline, and also the guidelines of the ATA updated, and I'm going to refer to Professor Susan Mandel online presentation about the updates of the American Thyroid Association. And now, if a physician is confronted with a patient with thyroid nodule, whether detected clinically or by chance during doing ultrasonography or CT, what should we do? Apart from history and physical examination, which is very important because history regarding the age, previous family history of malignancy, of thyroid malignancy, irradiation, and all these features are important in tackling nodules. And but the most important lab to start with is TSH. If the TSH is normal or high, we should go to the ultrasound. This is the next step. And ultrasound is done to do what we call risk stratification. So ultrasound in patient with normal or high TSH. And high TSH meaning the hypothyroidism, primary hypothyroidism. So the presence of primary hypothyroidism does not exclude malignancy, and this is an important point. On the other hand, if the TSH is low, as you see, this is hyperthyroidism, and in this case we do scan, whether technetium or radioactive iodine scan, and if the nodule appears hot or warm in the scan, this good sign. We don't need to do any further investigation. We go for the treatment, whether surgery or radioactive iodine or even long-term medical treatment. But if the nodule is cold or not functioning on the scan, we should go again to the ultrasound and so on, so on, so on. So again, we don't do a scan routinely for any nodule, only if the nodule is having low TSH to exclude warm or hot nodule, because these warm or hot nodules are not malignant usually. For the risk stratification, I will allude to the American Thyroid Association, and you can see that they have 5 types. Where on the top, high suspicion of malignancy, intermediate, low, very low, and benign. Let's go slow by slow, going first to the high suspicion, the first row. And these are on ultrasound. I mean the high suspicion on ultrasound. If you have microcalcification in hypoechoic nodule with a regular margin, this is bad. Hypoechoic nodule, a regular margin, also this is bad. And hypoechoic taller than wider is bad. Extra thyroid extension is bad. And also the presence of interrupted calcification, this is not good. The presence of thyroid lymph nodes, suspicion lymph nodes. Intermediate suspicion if it is hypoechoic with a regular margin. Low suspicion if it is hyper or isoechoic. I mean by isoechoic is the same as the thyroid. Hypoechoic, as you see, is similar to the muscles surrounding the thyroid. This is the strap muscles. So if it's the same as the strap muscles, this is hypo. If it's the same as the thyroid, this is isoechoic. If it's more than the thyroid, this is hyperechoic. And of course, low suspicion, there is partial cyst with no suspicious features. Very low suspicion if it is spongy like this one, like a sponge, or partially cystic nodule with no suspicious features. Of course, if it is simple cyst, it is benign. We don't do anything for this. I'm going to look next to the thyroid classification, the thyroid imaging reporting and data system. This is for American College of Radiology. And this is very famous because if you get an ultrasound report, the radiologist will write tier or TR3, TR1. Why they do that? They go for the composition, whether it's cystic or spongy or mixed, they give a score. For echogenicity, whether hyper or hypo, they give a score. For the shape, for the margin, if it's regular or irregular, they give a score. And also for the presence of echogenic foci, like microcalcification or punctate foci. And they give a score. And if the score is 0, this is TR1. If the score is 2, this is TR2, no suspicion. 3, this is mildly suspicion. If the score between 4 and 6, this is TR4, and this is moderate suspicion. If the score is 7 or more, this is TR5, high suspicion. So this is important to look for the TR in the report of the ultrasound, and it's you can do the ultrasound yourself as endocrinologist as well. And also the ETA, the European Thyroid Association 2023, they did the same categorization or risk stratification. And they call it 1 to 5. 1, of course, is normal, no nodule. 2 is a benign nodule like pure cyst, spongiform. 3 is iso or hyperechoic with no suspicion features. 4 is mildly hypoechoic with no suspicion feature. And 5, when you get suspicion feature of the nodule with hypoechogenicity, being irregular, margin and shape, microcalcification, and marked hypo. This is the major bad signs on ultrasound. And the next step is after doing the ultrasound to ask yourself whether should I send the patient to do fine needle aspiration, yes or no. This can be done blindly or ultrasound guided, as you can see. They put the needle and you target the nodule. And again, let's go to the guidelines when to do the fine needle. According to the American Cardiology of Radiology, if it's TR1 and 2, they don't do fine needle. TR3, you do fine needle if the size is more than 2.5. TR4, you do ever needle if the size is more than 1.5. And for highly suspicious, you do it if the size is more than 1 centimeter. This is according to the American cardiology. According to the American radiology, sorry. And going to the American Association, they did almost the same. For high and intermediate suspicion, do biopsy if it's more than 1 centimeter. Low suspicion, more than 1.5 centimeter. Very low suspicion, more than 2. Benign, you don't do anything. And usually, if there are suspicion lymph nodes on ultrasound and high-risk patient who's having family history, of course, you can change your mind. And according to the Thyroid Association, you can see that they recommend fine needle aspiration for Thyroid 3 if the size is more than 2 centimeter, 4 is more than 1.5 centimeter, and 1 centimeter is exactly like the ATA. 1, remember 1 if it's high risk, 1.5 it is intermediate risk, more than 2 centimeter if there is low risk, while in the thyroid they recommended more than 2.5 centimeters. So it depends on the guidelines you are using. But now I'm going to allude to the new update of the 2025 guidelines for the American thyroid, just released in the presentation of Professor Susan Mandel from USA, and the publication is still to come. And they said thyroid should be modified because it's applicable only for low-risk patients. Sometimes when you follow the thyroid, you underestimate the risk of malignancy. Because if you have markedly hypoechoic 3 points and solid 2 points, the risk for them is 12%, while actually the risk of malignancy is 40 to 45%. And the same occurs with isoechoic nodule. So it seems that they have seen that they need to update the classification on ultrasound. And that's why they updated it, they changed it in 2025. High suspicion of malignancy, the risk is more than 50%. Intermediate is is between 20 and 15. In the old terminology was less. Low suspicion 3 to 20, very low suspicion less than 3, and benign less than 5. This is the risk of malignancy according to the ultrasound. And they have changed it from the 20 to 15. Also, why they did change is the picture of the nodule. They said it's markedly hypoechoic, is dark as the strap muscles I have shown you. Hypoechoic, less but not markedly. Iso is the same as the thyroid tissue. Hyper is more than thyroid tissue. And they put very important what they call SSF, the solid nodule suspicion feature, SSF. Irregular margin, this is, you see, punctate echogenic foci like microcalcification, macrocalcification, and being taller than wider. So these are the 4 important features you should look in the ultrasound picture of your patient nodule. And this is one of our patients, show the typical irregular margin, hypoechogenic, and the punctate foci, so microcalcification. And the same patient, irregular, hypoechoic with the punctate calcification. And also one of our patients got papillary carcinoma on top of Graves. And this is important because patients with Graves, if they got nodule, the rate of malignancy is only 5%. It's not only, it goes up to 5%, to 20%. So if you get Graves or even Hashimoto with a nodule like this, you have to think about malignancy. And according to the 88-2025, they put this table. I like it very much. So if it is markedly hypoechoic with 2 or more or only 1 suspicion features, it's high risk of malignancy. If it's 0, it's intermediate risk. Hypoechoic with 2 or more, this is high. Only 1 features is intermediate. No is low, very low. Isoechoic or hyperechoic with 2 or more of these features. So even if it is iodechoic with calcification, irregular margin, taller than wider, it is intermediate. Only if there are no features, you go. So this is very important if you expect to do fine needle aspiration. The problem with cystic lesion, you say cystic is more than 10% cystic. And in the entirely cystic, usually benign, you don't do anything. In the partial cystic, you depend on the features. Like this is one of the patient with papillary carcinoma. This is partially cystic, but you see that the solid part of the nodule is irregular with punctate calcification. So this is a high rate of malignancy. This was the papillary thyroid carcinoma in a mixed nodule. So if the nodule is mixed, doesn't mean that it is normal. You have to go to the features of malignancy, as I mentioned, irregular border, microcalcification, taller than wider, and even macrocalcification, because in the old time say macro is benign. No, macro can be abnormal. And here it's the importance of the calcification, because in dense calcification sometimes very difficult to do FN needle. So if the calcification is regular, you don't do anything because low suspicion. But if the calcification is interrupted or there is protrusion soft tissue from the calcification, so this is a nodule calcification protrusion, this is a high suspicion, so you have to do something. And this is again the new algorithm proposed by the ATA to be published in a few months, inshallah. This was a presentation by Professor Susan Mandel. And according to the ATA, as I mentioned, high suspicion, more than 50%, intermediate suspicion, 20 to 50% risk of malignancy, and this is the low suspicion and very low. I've repeated that previously. And very interesting, say, if there is high suspicion, as I told you, you do fine needle aspiration more than 1.5. In the old time, it was 1 centimeter. Now they're going up to 1.5 centimeter. Intermediate suspicion, you do fine needle if it is more than 2. Low suspicion, more than 2.5 centimeter, very low. And benign, we don't do anything according to the ATA. And if the fine needle aspiration doesn't show anything, like what you need to do, you need to either repeat it if it's non-diagnostic, or if it is Bethesda 3, I will tell you that in 1 minute, inshallah, of the patient having a discrepancy between ultrasound. So ultrasound, you see high risk, and serological malignancy is benign risk. Here you have to repeat if there is discrepancy between the ultrasound and fine needle. if it is less than 1 centimeter, unless there is a history of head and neck irradiation, a strong family history of thyroid cancer. So in these cases, you have to put a needle even if the size is less than 1 centimeter. What about the classification of the fine needle report? We've got the Bethesda, 6 grades, non-diagnostic, benign, atypical follicular lesion, follicular neoplasm, suspicion for malignancy number 5, and malignant. These are the 6 grades. For non-diagnostic, what you did in non-diagnostic, you have to repeat it. Fine needle, as I'll tell you. Benign, you observe, as I'll tell you. For the atypia of unknown etiology or the follicular neoplasm, you have either to repeat or consider molecular testing, which is not available in our country. And this is genetic. They take the sample from fine needle and then they send it to the lab for abnormal genes, as I will tell you. And the other option, sometimes you do that in Egypt, is for 3 and 5, it is high suspicion, you send the patient for lobectomy. And this is the molecular finding. If it is positive, this means that high risk of malignancy, you send for surgery. If it's negative, you wait and see, don't send for surgery. And this is the genes, the BRAF-like gene and the RAS genes. You look for that in the molecular findings, which is not available yet in Egypt. And it's not available in many, many countries. So according to the ATA, as I tell you, if what to do, follow up. If the risk of malignancy, if the biopsy say is okay, 2, or the risk of malignancy is high, you have to repeat all nodules. If the intermediate risk, you follow up the patient after 1.5 to 3 years. You don't do that every 6 months. If the low risk, follow up every 3 to 5 years. Follow up ultrasound. And this is more reluctant because in the old days, we used to do it every 3 months, every 6 months. No. If it is intermediate, you do it every 1.5 to 3 years. It is very low. You don't repeat the fine needle. And you send the patient only for surgery if the nodule is symptomatic, if it is benign, and if there is abnormal calcitonin in family history of medullary carcinoma, and also if the nodules intermediate Bethesda 3 and 4, you can send for surgery if you don't do follow-up. And nodules 5 and 6, you send for, this is very important, 5 and 6 cytology, you have to send for surgery. This is very important. 5 and 6, send the patient for surgery. And again, I'm repeating that usually benign nodules, they continue benign. This is another study published 3 years ago, and the malignancy rate is very, very, very small in patients with benign nodules. So we have to reassure the patient. Lastly, I will speak shortly in 1 or 2 minutes about the active surveillance. In Japanese group, this was 25 years ago, they have suggested that if there is a microcarcinoma, less than 1 centimeter, you don't need to do surgery. In these cases, even if it's documented carcinoma by fine needle, here you can follow up this patient and close observation. The recommendation is if the size is less than 5 millimeter, the tumor is not close to the thyroid, no lymph nodes, no family history, no irradiation, and no psychological pressure, you can follow up this patient every 6 months or 1 year. Send for surgery on the tumor is increases on follow-up, or lymph node will appear, or the patient changes his mind. You know, patient knows that he's got papillary carcinoma, and it's very difficult here in Egypt to convince them and the family just to wait and see. But in other countries, they can do that. And also this important paper, they do active surveillance even for nodules above 1 centimeter. And this was published last year. And they showed that no much change if you do surveillance, close surveillance to patient with very, very low risk. And I will end by saying that apart from surgery cytology, now the ultrasound-guided ablation is becoming to be coming in Egypt. And the ultrasound-guided ablation, sometimes they use it for papillary carcinoma of less than 1 centimeter, and sometimes they do it for the lymph node biopsy recurrence. And this is show they include the needle and then they ablate by heat and or microwave. And what about the PET scan? PET scan, usually you don't do it routinely for thyroid nodule, but if it is done for any reason, patient with malignancy, they do PET scan. If the PET scan show a very hot nodule, the risk of malignancy is high. So you have to biopsy it if it is more than 1 centimeter. If there is diffuse uptake, do not do anything because usually it's chronic lymphocytic thyroiditis. So remember, because you can get a PET scan saying there is uptake in the thyroid. So remember that. And at the end, I will conclude, ladies and gentlemen, Madam Chair Lady, Mr. Chairman, I think that if you get thyroid nodule, you have to start history and physical, do TSH. If TSH is low, you do the scintigraphy. If it is hot, you don't do fine needle because usually it is benign. If it's cold, you go for the fine needle. If the TSH is normal, you go for the ultrasound. If the TSH is elevated, again, apart from doing the profile for Hashimoto thyroiditis, putting hypothyroidism, but again, this does not exclude malignancy. You have to send the patient to do ultrasound and then fine needle accordingly. So what they said, if in the European thyroid, if it's 2, and what you could, you don't do fine needle, you follow the patient. If the nodule is more than 1 centimeter, every 3-5 years. If the less than centimeter, no further evaluation. And you do fine needle only when there is on follow-up significant growth or new features of malignancy. If thyroid 3, if the size is more than 2 centimeter, FNA. Less than 2 centimeter, again, surveillance or fine needle if it grows. If the thyroid 4 less than 1.5 centimeter, again, you do follow-up every year or fine needle if there is significant growth or change in the features. More than 1.5, fine needle. For the thyroid 5, more than 1 centimeter, fine needle. Less than 1 centimeter, follow-up every 6 to 12 months, remember that, and you do biopsy if there is significant growth or changes in the feature or abnormal lymph nodes or extrathyroid extension. And you do that fine needle, and you have in this table they have put fine needle and the ultrasound imaging together to get the conclusion. If Bethesda 1 and by fine needle and the thyroid is 3, if it's more than 2 centimeters, you repeat the FNA. If it doesn't show, you can go what you call core needle biopsy, which is usually not frequently done. For the thyroid 4, if it is more than 15 millimeter, and for thyroid 5, more than 1 centimeter, you repeat the FNA. For Bethesda 2, if it is more in the thyroid 3, more than 2 centimeter, and thyroid 4, more than 1/2 centimeter, you repeat every 3 to 5 years, not every 6 months. And again, repeat the FNA if there is significant cross. For thyroid 5 with Bethesda 2, you have to more than 1 centimeter, repeat the fine needle. So, and if there is Bethesda 3, you go to the ultrasound say thyroid 3, more than 1 centimeter, repeat the FNA. 4, more than 1 centimeter, you repeat that. 5, more than 1 centimeter, repeat the FNA. For Bethesda 4, here, if there is 3 and 4 and 5, either surgery or molecular testing, it is not available. So here you can consider surgery for 4. For 5 and 6 pathology in the fine needle Bethesda, you send the patient for surgery if the thyroid is 3, 4, and 5. So in this table by the ATA, this was 2 years ago, this is very nice. You can find it in the literature. They have combined the ultrasound picture and they combined the pathology picture by fine needle to get a conclusion whether to follow up the patient or to send the patient for surgery. And at the end of the day, ladies and gentlemen, if you get the nodule, whether purple or incidentally discovered, you do the TSH. If the TSH is low, you do the thyroid uptake. If the uptake is hot, no biopsy. If the kid is cold, do biopsy. If the TSH is normal or elevated, do ultrasound. And if the ultrasound meets the criteria for biopsy, as I mentioned, depending on the grade, you don't do biopsy. Otherwise, you do biopsy. And after having the results of the biopsy, according to the ATA table, this is very important table. You can put it in your own clinic, and you can detect what to do for this patient, whether to send for surgery or not. And thank you very much for again for the invitation, and thank you much for attention. And I hope that next time I'll be physically, I'll be proud and honored to be physically among your kind self. And thank you again.
Thank you very much, Dr. Samir. I have two questions because we have a lot of problems here with doing FNAs. The main, most people have a very wrong belief that if you do an FNA and it was cancer, it will spread. And they sometimes go directly for surgery without doing an FNA, and they have an unnecessary surgery that they really didn't need. I hope you could say a few words for the physicians, just that it does not spread the disease if they do an FNA.
Yeah, thank you. Thank you for your comment. This is very important because even here in Egypt, every day, even yesterday, one of the patients say, if I put a needle, I should go immediately to surgery. Say, no, if it is benign, there is no risk. And if it is malignant, it doesn't spread, because this was very old saying. Even in Egypt, this was maybe 15 or 20 years ago. Doctors used to tell them to the patient, which is not correct at all, because there are no data that putting a needle will leading to spread of malignancy, even if it is positive. And this is very important to convince the patient and convince us as well. Thank you very much. Very nice comment.
Okay, the second question. 1 minute, doctor. Sometimes we have patients that have cysts in the thyroid, and they are very big in size, 4 centimeter, 5 centimeter, or sometimes even bigger. And we sometimes aspirate them. Some of them improve, and sometimes the fluid reaccumulates in the cyst. How many times would you do an aspiration before you consider sending them for surgery?
Another important question, very clinically applicable. For pure cyst, and you are sure that it is benign and it's only symptomatic because it's big, if you aspirate it, 90% they will reaccumulate again. So we used to do, and I think you can do that as well, is what you call ethanol injection, just to induce fibrosis and avoid the recurrence. So this is one way to do it. But to do repeated aspiration usually is not very feasible, because if you do it several times, it will reaccumulate. So the best way is to send the patient for surgery only for the symptom, because sometimes it's, and of course the feature. So if it's very ugly nodule and very compressing the trachea, you have to send the patient for surgery. If he refuses the injection with ethanol, it's injection with ethanol. Usually we didn't have any complication with that. Only if the cyst is near to the vocal cord, some patients, they have abnormality of the voice after ethanol injection because it irritates the vocal cord. Otherwise, if it is away from the recurrent laryngeal nerve, you can do it safely. Thank you very much.
Dr. Khaled, one more question, please.
Prof, thank you very much. I'm Dr. Qatta. I'm a cardiologist. As you know, the radiation, it's a risk factor for
cardiologist.
Yes.
I mean, many of the failure of thyroid are actually from cardiologists.
Yes.
Because
my question to you, what's precautions? What your advice regarding the follow-up or the screening for intervention cardiology and radiologists regarding the thyroid?
You mean for the cardiologist want to follow? A patient with thyroid disease, of course they can.
I mean for the intervention cardiologist, radiologist who working in the field of the radiation. So the risk factor for them. What's your advice?
Okay, I got your question. Sorry, I got your question. Thank you. Very important. Actually, we did. If you go to the literature, we presented that the ATA study we've done in Alexandria is to examine the patient after doing PCI. Only the patient. We didn't do that for the doctors, and it showed that even the irradiation given to the patient shortly, it will have an effect on the thyroid, can lead to temporary thyroid dysfunction. For the physician, for the cardiologist on thyroid, usually they put a tag, as you know, and for the cumulative effect on irradiation, and they stop it. But for the effect on the thyroid, actually, it will be a very good point to do a research. And you have given me a new idea just to do it for our cardiologists, because our cardiologists, they do 10 or 20 times PCI every day. And so it will be a good idea to examine the thyroid tissue in during doing that for the radiologist or maybe for the cardiologist. And I think it's a good point for research. Thank you very much. Very, very nice question. Thank you.
Thank you very much, Doctor. We hope to see you here soon.
Yeah, thank you. Thank you very much. Thank you.
Okay, so now we'll have a break. Let's reduce it to 20 minutes. Okay, 20-minute break, and then we'll start the next session.